Hi, I'm Dr. Rahi Victory, a reproductive endocrinology and fertility specialist, board certified in Canada and the US, and you are watching Fertility Fact or Fiction, our weekly show where we review all the myths and the facts and go over how to make your journey better. We always present a case or an article first, and then we review that so that you can get better educated, and then we answer your questions live. So stay tuned and watch till the end, and we will get your questions answered. Almost always we get through most of them, so hopefully you'll stay with us to hear what the answers to your questions are. And make sure that you acknowledge my dear friend Tarek from Ibrahim Strategies Group, who likes to be acknowledged when you're asking the questions. Tonight's topic...
It's a self-esteem issue.
It's a self-esteem issue, okay. Are we screen sharing right now?
No, I am.
Should I set that up?
Yeah,
I thought I did. Right.
No, you are. You're good.
Oh, yeah. Okay. Yeah. So tonight's topic is about whether or not women who do not have, or couples that do not have a lot of embryos, should go ahead and do PGT testing. So let's just talk about that briefly. So many couples will not have a lot of embryos to use. They may have 1, 2, 3, a relatively low number. And in that situation, the question is, should you test the embryos to see if they're genetically normal, or should you not test the embryos to see if they're genetically normal? Because some people say testing them is beneficial, you reduce miscarriages, you increase the chances of success per embryo transfer, while other studies have shown that there may not be so much of a benefit. So the question really is, what's the best approach to this? And the answer is, we don't know for sure. So there have been multiple studies done, small and large, and in some of the studies they showed that there was a benefit to doing it, but then in the follow-up studies they showed that there actually was no benefit to doing PGT. But most of these have been in good prognosis patients, especially for the ones that did show a benefit, where these patients had at least 2 or 3 good quality genetically normal embryos. And so the question is, well, that doesn't necessarily apply to everybody. What if we start looking at subpopulations where the patients don't have as many embryos, their ovaries may be weaker, and so on? And so in this particular study, that's exactly what this group looked at. They wanted to know, what is the benefit, if any, of doing PGT in patients who have only 1 to 3 embryos to use? And so they analyzed this as a retrospective study, looking backwards at one pool of data for women that only had 1 to 3 embryos. And they had done PGT testing on them to see if any of them were normal. And then they compared that group to a control group, which they matched. And I'll go through all of those details with you. So the first thing to know, the title is Pre-Implantation Genetic Testing for Aneuploidy in Patients with Low Embryo Numbers. And then there's a colon and it says benefit or harm with a question mark. So the first thing to know about this study was done in Toronto, Canada. Yes. And it was done by people that I know well. So Paul T. Chang is the second author, and he was actually my junior resident. And Jim Mariano is the lab director at Trio, which is a great fertility center in Toronto. And Jim is a wonderful guy. I've spoken to him multiple times. He's a wonderful lab director and embryologist. And Robert Casper, who is far and wide acknowledged as being one of the gods of the infertility world. He's an extraordinarily bright man, has numerous patents to his name, and has probably invented more stuff than most people will even dream of in their lifetime. So a great group of people behind this study, definitely people that know what they're doing. I don't know the lead author, but I'm assuming he's either a resident or a new addition at Trio Fertility there. So essentially what they wanted to do in this study, as I mentioned, was look at this question. So how did they do it? They selected the patients that had between 1 to 3 embryos retrospectively, and these were people that had this from their first or second IVF cycle, and they had 1 to 3 blastocyst embryos, and it was done between 2019 and 2020, and they had embryo transfers up till April of 2021. So the study group was 130 patients that underwent PGTA on all their embryos. And the decision for PGTA was just individual. If the patients wanted it, they did it. And if they didn't want it, they didn't do it. So there's definitely some bias there because these may be people that maybe had gone somewhere else and had had bad outcomes or were worried about something or had a history. So, it could skew the data a little bit. And that's really important to remember. The control group, they matched to 130 patients also who had the same age, BMI, and blastocyst number, but did not use PGTA as part of their protocol. And I've highlighted that all in yellow. I'm not sure if we're still sharing or not there, but so they looked at the cumulative pregnancy and live birth rates, and this included all fresh and frozen embryo transfers during the study period. Now that's something very critical to remember because if you're doing a PGT cycle, you're not going to have a fresh transfer. You're going to end up with a frozen embryo transfer. So a little bit of this is comparing apples and oranges because some people got that fresh embryo transfer. Some people were getting a frozen embryo transfer. And not that one's better than the other, but it is different. And so it's kind of hard to compare those two groups exactly. They excluded people that had donor eggs and people that had endometriosis, as well as people that had 2 or more previous miscarriages because they felt that that was not reflective of the group overall that they wanted. And they eliminated people that had mosaic embryos as well. Excuse me. IVF protocol, pretty standard protocol. Their PGT was a standard PGT technique. There was nothing really exciting there for me to highlight for you. So the results, they had actually started out with 191 cycles where 3 or fewer blastocysts were obtained, or at least biopsied. 34 cases got excluded because they had endometriosis. That makes sense. Or 2 or more miscarriages. A further 27 were excluded because of the fact that they had a mosaic embryo. So this is a little bit of a problem because those cases could have been valuable because mosaic embryos actually can be transferred as long as they're not high-level mosaics, and 50% of them will yield a benefit. So again, anytime we're analyzing a study and anytime we're presenting you with data, you really got to dig down into the data and look at the study and make sure it is a good study that you can reference and use based on very solid data. In this case, the first problem is they weren't comparing apples to apples. They were kind of comparing apples to oranges because there were fresh transfers as well as frozen. And the second problem is they eliminated a bunch of cases because of mosaic embryos. And that's a fair number of cases there, almost 10%. So could that have skewed the data? Yes, it's very possible that it could have, had they included those embryos, which we now know it's okay to transfer. In terms of the study population demographics, you can see it right there. No difference in any of the features other than that the PGT group actually almost had more eggs present, but it wasn't statistically significant. It was close. As you can see, it's 0.058, has to be less than 0.05 to be significant. So the age, the body mass index, the total number of eggs, the number of 2PN was normal. The mature number of follicles was the same. The total number of blastocysts was the same. And the total number of embryos was actually exactly the same. So that was great. Obviously, in the PGT, they had 90 embryos total that were normal, which was 34% of the total number of embryos that they had. And in the control group, they didn't know because they never tested them, obviously. Okay, so here's the first important fact. Altogether, out of 130 IVF cycles in the PGTA group, there were 26 babies born compared to the control group in which there were 56 babies born. So more than double the number of babies were born in the control non-PGTA group compared to the PGTA group, 26 to 56. In addition, there were still another 83 embryos in the control group, but only 13 embryos left in the PGTA group, which could potentially increase the cumulative pregnancy rate because you now have more babies being born because the control group could have come back for multiple other transfers. We don't know how many of them would have worked, but that potential is there based on the initial results. So just looking at these various numbers, you can see at the top here, and I'll kind of bring it down for you and expand it there. So the first one is the PGTA for 1 to 3 blastocysts. So 70 cycles had euploid embryos, 60 cycles out of the 130 had no euploid embryos. So almost half of them had no normal embryos. They had to go back and do other cycles. From the first frozen embryo transfer, 36% had a live birth. From the second, 0%, and from the third, 1 out of the whole group had a live birth. When they looked at the other side of this, which was the group that had no PGT, the control, so 45 ended up freezing all of their embryos. 85 had fresh transfers. So this is that first inflection point where you got to realize this is not apples to apples, this is apples to oranges. 28 out of the 85 actually had a live birth, which is very similar to what you got with the first frozen embryo transfer. But then when they had the frozens as well, that now they got another 33% there. So when you took your fresh and you took your first frozen, you cumulatively had quite a high number of pregnancies. From 22 second FETs, almost a quarter of them, a little bit more than a quarter, had a live birth as well. And then 6 had a third FET, and none of those were successful. So also really important to keep in mind. When they looked at it in terms of live birth rate per retrieval, it was 20% in the PGT group, and it was 43% in the control group. So this is a huge number, because getting 43% in a group where they actually don't have a lot of embryos is actually by itself very impressive. And this was highly statistically significantly different, because you can see right here that it is below the 0.05 mark. It's way below that. So that's very, very critical. And essentially, like I said, they've got this 0.2 here and they've got the 0.43 there. So very, very significant numbers. You're looking at over double the rate of live birth when they did not do PGT. Again, keep in mind, we can't make generalized conclusions based on this, but this is concerning data, because we frequently tell our patients you should consider PGT when you don't have a lot of embryos, because it may be impacting the egg quality, and we anticipate you'll have a higher number of abnormal embryos. But what it's not accounting for is the fact that some of these embryos can self-correct, and some of them will be mosaic, and so we need to actually include those in the study. Okay, so we're going to go to the next page. And on this page, they did subgroup analysis based on age. Actually, let me go back for 1 second, sorry. So down here at the bottom, they had the increase in cumulative live birth rate with each embryo transfer. So in the blue at the bottom was the case group, which had the PGTA, and the orange in the upper line there is the group that was the control. So as you can see, the cumulative live birth rate, obviously there were no fresh ones in the PGTA, so that's not, that first part of it there is not really fair to look at. So this part here, you got to ignore, because it would have been 0. So that shouldn't be a continuous line. So at FET1, you've got this kind of almost 20% rate. FET2, you're sort of maintaining it at that rate. And FET3, you're getting that final achievement of hitting the 20%. But when you look at the other group, in the control group, it starts at about 22%, and it just keeps going up and up until you get to the second FET. Between the second and the third, there was no change, because they had that 0% in the third FET, but still you're getting a continuous increase with these untested embryos, whereas you're not getting that with the PGT group. It was quite flat across the board. When they broke it down by age groups, they have kind of 2 different versions of it to look at here. It was not statistically significantly different, although it was suggestive or trending towards significance. And so I can highlight that for you here down at the bottom. you can see that the live birth rate was 27% in the PGT for women under 38, and it was 51% in the control group for women under 38. So it was close to significance, 0.054, so definitely suggestive of a trend, but not enough to call statistically significant. When they looked at the women who were over 38 or 38 and older, same kind of findings, 13% in the PGT group, which is really quite low for women that are over 38. That's a very low number of live births. And then in the control group, they had 31%, which is obviously substantially better. Again, it's 0.065 for the p-value, which means it is not statistically significantly different, but it's a trend. Anything under 0.07 we consider a trend. So, and you can see it down here in the graphic. Essentially, it's the same thing. It's just demonstrated to you graphically here. So on the right side, on my left side, I can see that you're looking at the under 38 group, and then on the right side, it's showing the over 38, and they looked at live birth rate per embryo transfer, and then they also looked at live birth rate per retrieval. Live birth rate per embryo transfer was not statistically significantly different between the two, but it was very statistically significantly different based on per retrieval. Now, neither of these were statistically significant in the per retrieval portion when they divided it up into the different ages, as I showed you before, but there are those trends that are there, and that's something important to look at. Oops. So the final portion of this was, again, looking at the blastocysts that they got. I'll show it to you in the graphic form here. So this is kind of important. When you looked at the cumulative live birth rate for women with 1, 2, and 3 viable blastocysts, so they looked at how many blastocysts they had. If you only have 1, there's no difference between PGT and control. If you had 2, the control group did almost 3 times better when they did not have PGT testing compared to the group that did, and that is highly significant. And then again, when you had 3, they showed that it did not make a difference. So this may be so focused and narrowed down that we actually need to decide based on the number of embryos that you produce, whether or not this is something that is valuable for you. So they essentially concluded that, in this subgroup, 3 or less embryos, it may actually be detrimental to do the PGT because it's actually making you do more cycles, inflict more emotional and psychological trauma on the patients, and you actually may end up losing valuable embryos that otherwise could have been transferred and may have resulted in a normal pregnancy, which is the assumption in the control group, because obviously you're going to assume that you're having the same number of abnormal embryos, but maybe some of those abnormal embryos are actually working. And we reviewed that in the David Barad study a while back, where they also said that putting in genetically abnormal embryos, especially the mosaics, can actually yield a normal outcome. So in this particular study, they are strongly advising people to not do PGT if you have fewer embryos, and that it actually increased the time to pregnancy, cost more, and was much more frustrating. So they're saying our data suggests PGTA has limited utility in the subpopulation of women with few embryos and may cause harm. So analyzing this study, am I going to jump on the bandwagon of don't do PGTA in these patients? Not yet, because again, there are some flaws in this study. Apples and apples? No, it's apples and oranges. They're comparing fresh versus purely frozen transfers. And they eliminated the mosaics, which is very problematic because those mosaic embryos have a chance. So I'm not sure I'm there yet, and it certainly begs having a randomized controlled trial, but it is very compelling to consider whether or not this makes sense. And as my amazing lab director, Dr. Khosravi, pointed out to me, there is yet another study which actually supports this one and says that it is not useful in women that don't have a lot of eggs. So is it a fact or a fiction that PGT is detrimental and not necessary in women with 1 to 3 or fewer blastocysts? The answer is I'm not 100% convinced yet, but it actually looks like it may be a fact that it is detrimental and not of any significant benefit to you. So that's fertility fact or fiction for this week. Thank you for watching. Make sure you click the like and subscribe button to learn about more exciting videos. We have one we're going to be publishing soon called the Top 10 Reasons Your IVF Cycle Failed. And now we're going to be taking your questions live.
Hi, Dr. TV.
TV.
Can fertility diagnose silent endo? Only a lab can.
Only a lap. So only laparoscopy is going to detect if you have endometriosis or not. The fertility absolutely cannot detect endometriosis. There are no tests yet for detecting endometriosis.
Hello, Dr. V. Hi, T. I'm on a beach, but nevertheless, it's Tuesday fact or fiction time.
That's awesome, man. Well, thank you for watching from the beach. I love that. That's very cool.
So she goes on to ask, so quick one. What's the desired estro and progesterone levels to have right before an FET?
So we don't really monitor the estrogen levels. There was a study, I can't remember if it was Japanese or Chinese, that we did review on the show, which said that there was a minimum threshold of estrogen that you wanted to have. You didn't want to be over a level and you didn't want to be under a certain level. I think it was 100 picograms per milliliter. Don't quote me on that. I have to go back and look at the study. We really don't pay too much attention to the estrogen level, but from the progesterone standpoint, it's definitely important to look at your progesterone levels. So we use 40 to 100 nanomoles per liter, which is 10 to 30 nanograms per mil.
Is it recommended to do a modified natural cycle if you are premenopausal?
Yeah, it's recommended to do a modified natural cycle if you're anybody. So overall, the data shows that for women that are doing FETs, the modified natural or a letrozole cycle will yield a higher chance of success. So that's the way you should be going.
Yay, Learning Tuesday. Thank you, Dr. V&T. You guys rock. Question: what causes a period delay in the resting month after IVF retrieval, and anything we could take to get it back? Currently on CD44.
Oh, wow. Well, you could be pregnant. So I definitely get a pregnancy test in case one of the eggs kind of lingered and you happen to have sex at the right time. So I definitely get a pregnancy test first. Typically, that's not the case unless your body's very stressed out or you were close to menopause or something like that, or somehow your thyroid is off or prolactin is off. So unless you're on medication or there's a hormonal abnormality, your cycle should be coming back. You could certainly take progesterone, but don't take it unless you have had your beta HCG checked because you might be pregnant already. And let's hope that's the case.
Also, is a Lupron protocol one shot for 3 months or one shot daily for 3 months?
Well, you could do either, and it depends on which Lupron protocol you're talking about. If you're talking about an endo protocol, it's Lupron and letrozole for 3 months. So we just use Depo Lupron, which is one shot for 3 months.
The question about that they're on the beach.
Yeah.
From California.
California, that's awesome. Wow, very nice. Well, thank you for watching from California. Actually, we have a lot of people who watch from California. So yeah, a lot of my friend Amy's followers follow us as well. So thank you for watching. We appreciate that. And let us know how it is in California. Take a picture and send us a picture.
Hello, Dr. V. I have a high AMH, tend to make lots of follicles, but
Awesome.
just a few mature ones.
Oh.
What do you recommend? Will taking metformin help?
Metformin, inositol, NAC, coenzyme Q10, resveratrol. Human growth hormone may help because it has been shown to improve the number of eggs that are mature. Definitely double trigger. It's very possible that because you have PCOS, they're not using the HCG to avoid hyperstim, but a small amount of HCG can go a long way towards maturing your follicles. So all of those would be the things that I would be looking at, and then make sure they're waiting until you have the right sized follicle.
What's your opinion about using vitamin D drops rather than the gel VD tablets?
I don't have an opinion. I think whatever is best absorbed in your body is probably fine. So you could use either one and that would be okay.
If we have a phone appointment with you,
Yeah.
can we request to be over Zoom instead?
Yeah, for sure. I do Zooms like, 10 times a day. So no problem at all. Happy to do that.
Is gravel safe to take during pregnancy, and what is safe to take for headaches?
You know what? We should do a video on that.
Yeah.
What meds are safe
100%.
in pregnancy? We should definitely do that. Although we'll probably get in trouble if it ever comes out that one of them is bad. Gravol, to the best of our knowledge, is safe in pregnancy. There are no contraindications to using Gravol that I am aware of. So full disclaimer, I can't promise you anything, but there are no contraindications that I am aware of to using Gravol. For headache, Tylenol is safe. There is some controversy about it, and I know there's a class action lawsuit for Tylenol now because they're claiming it can cause autism. I've never seen that. My own wife used Tylenol during pregnancies. I mean, we have bucket loads of people on Tylenol while they're pregnant, and then after the pregnancy when they're breastfeeding, and it hasn't seemed to cause any problems. So that's safe. 1 or 2 baby aspirin would probably be safe as well. For people that get very severe headaches like migraines, we actually use Maxaran, and I still haven't figured out what the mechanism is, but it does seem to cause the migraines to go away, and it's one of the only safe medications you can use for migraines when someone's pregnant. So any of those would be a safe bet. If it's getting worse than that, you need to be seen. And with any headache in pregnancy, if there's any chance it's associated with preeclampsia, you must go get seen. That's very, very important. Don't forget that.
Do you keep your PCOS patients on metformin all the way through pregnancy, or wean them off?
No, I keep them on. It's controversial. There were studies that showed it reduced miscarriage, and there were studies that showed it didn't make a difference. But I figure if it's either no difference or reduce, and I can maybe prevent diabetes and sugar fluctuations, it's a good thing. So I think it makes sense to keep patients on it. I also don't love the idea of making people's metabolism take huge shifts when they're pregnant. I think your body kind of gets used to being here, and you don't want to do something that's going to kind of rock the boat. So we try and keep it very kind of low key in terms of change.
Where shall I send the pics from the beach?
Oh, send the pics from the beach. Well, I can't tell them to text me. Send them, DM me on Instagram. That would be cool. Yeah, just DM them to me on IG.
Hello, Dr. V. I have a high AMH and tend to make. Oh, we did that one.
Yeah.
Oh, interesting question. Hey, Dr. V and T. I think this is more for you than for me, for what it's worth.
Okay.
Did you always want to be in the fertility field, or did you have other plans when going to school?
So when I was 10, I knew that I loved kids, and I thought I was going to become a pediatric surgeon because I wanted to do something really cool, but with children. And then when I was in university, I went to a seminar where the individual that was giving the seminar was a pediatric surgeon, and I was so excited. And I went and I spoke to that person, who very rapidly told me it was the worst job ever, and I should not even think about it. So that was kind of depressing. And then I still loved kids. I knew I wanted to be a doctor. So my heart was set on either peds or OB. So then when I got into medical school, I wanted to do pediatric research, but the only person at Queens, where I went to medical school, that was doing it was actually an OB. And so he was doing research on how the labor process impacted whether children were born with asphyxia or acidosis, and leading on to very severe problems, brain damage, cerebral palsy, and so on. So in studying with him, he would make me go to OB clinic, and God bless him, it was the best thing ever, because that's what made me decide that OB was the way to go. Once I got into OB, I just loved everything about the fertility world. And so that was an easy jump for me to get into what I'm doing now. I did not know that I wanted to be on social media all the time, because social media didn't exist back in the days where we rode dinosaurs to school. So I had no idea about this. And actually, FFOF, fertility factor fiction, was the result of my realizing that the ERA test sucked and wanting to share it with everybody. And we wanted to review that with people and tell everyone what was good and what was bad. And then we just realized there were so many people out there that wanted their questions answered. And the show just keeps building and building because people are telling their friends and they jump on as well. So thank you for watching. Thank you for sharing with everybody. Keep sharing. But yeah, that's how we got to here.
For your patients on DHEA,
Yep.
do you have them continue taking it during stims?
During stims, yes, but not after. Like definitely not once they're done the stim, we take them off.
Thoughts on embryo glue and assisted hatching for embryos?
Yeah, so embryo glue has pretty good data for it now. There's meta-analyses, there's the Cochrane meta-analysis, there's a bunch of them. They more or less all show the same thing, which is that it's beneficial. We now include it in all of our transfers. We don't even charge you for it. Most places are charging about $500-600. My lab director said it was immoral not to use it, and so we had to include it. So now we pay for it for everybody. So you're getting embryo glue if you're doing your transfer with us. You just don't know it. As far as assisted hatching, we do assisted hatching. Very controversial, and there are no good studies on whether or not it's beneficial. But we do use it to help the embryos hatch out, especially if the patient's older, has had previous failures, has a thick zona. All of those things are really important. But generally speaking, we do it anyways pretty much for everybody.
Hi, Dr. VNT. I have to move my body for the day, but refuse to miss an episode. So I decided to use my headphones for the episode while following a workout vid in the background.
That is awesome. Wow, that is commitment. I love it. Thank you. You know what? We got to post that. Take a screenshot and we'll put that up. We'll delete your name. Don't worry, but that's amazing. Thank you for that level of commitment. I love that. That's very, very cool.
Hi, Dr. VNT. Can you please remind me of the letrozole dosing for preparing for a FET? My REI has been using estrogen, and I would like to try letrozole this cycle for grow lining.
Yeah, 5 milligrams a day is what we use, and that seems to work very well.
What are the side effects of stress on ER and FTE?
ER, endometrial receptivity, and maybe they meant FET, frozen embryo transfer. I'm assuming. Yeah, I don't know what the impact of stress on endometrial receptivity is. I've never looked that up. Stress is really impossible to quantify because I'm notoriously known for being immune to stress. Nothing stresses me out, whereas other people get very stressed from small things. So it's really hard to quantify stress because people have different interpretations of what is stressful. So it's a very hard thing to study. We do know that people that are stressed have reduced outcomes. There's no question about that. That has been shown over and over again. And there's also lots of data that shows that techniques to reduce stress can improve your outcomes. So I think that that's critical, but does it impact your endometrial receptivity? That I don't know. Will it impact your FET? Yes. The more stressed you are, the more you drive up your cortisol, the more you're stimulating abnormal hormone levels and inflammation. That's never a good thing for a frozen embryo transfer.
I think you're gonna like this one.
Okay.
Hi, Dr. VNT.
Okay.
Do you think
Yeah.
that the biopsy taken to do genetic testing could also harm the embryo?
Yeah. So there's controversy about that, but I actually do think it can, especially if the technique used is not great. So it depends on who's doing it, how much experience they have, how good they are at it. So for example, Dr. Khosravi, our lab director, rarely has embryos that come back saying insufficient material. My last embryologist constantly had them coming back saying insufficient material. And every time I said that, you know, we needed to get extra training on this, he would say, no, the place analyzing it doesn't know what they're doing. But the reality was that he just wasn't doing a good enough job. So we need to make sure that the technique that's being used is excellent and is truly exceptional. And that's not the case everywhere. Otherwise, yes, you could harm the embryo for sure. We are going to start playing with the idea of doing non-invasive PGT, where you can get cells from the surrounding fluid and send it, and they can analyze it. It's not as accurate, but it's interesting. So we're going to play with that for a bit and see if that gives us any kind of indication of what could work and what could not work.
What is the ideal TSH?
TSH?
Yeah, TSH before starting IVF stims. Ideal TSH before embryo transfer.
Less than 2.5 for both is what the Endocrine Society recommends. They actually say less than 3 for the first trimester and then less than 2.5, but everybody just uses that 2.5 now. So less than 2.5.
Do you suggest doing embryo PGT testing with donor eggs?
We were just discussing that before we had the show. So yes, no, and maybe. So in a donor egg population, depending on who you believe, your rate of aneuploidy is somewhere between 15 to maybe 25, 30% if your donors are young. So, and by young, I'm saying like under 30. So on the lowest end I've seen, it's 15%. The highest I saw was 50, but that was totally wildly unreasonable, and I don't believe that data at all. So let's say 15 to 30%. So in between there, somewhere, let's say like 20 to 25% to take an average. So really, you're biopsying on average 4 embryos to find one that's abnormal. So statistically speaking, it doesn't make a lot of sense. So if it's just for donor egg and it's going autologous back into the intended parent, then my answer is no, we would not advocate for doing PGT. A lot of our program is dedicated to helping either homosexual men or homosexual couples. And as a result of that, when we're helping those couples, they need a surrogate, or those individuals, they need a surrogate. Or if any other couple needs, a heterosexual couple needs a surrogate. The problem there is that our surrogates are sometimes asking to make sure that the embryos have PGT. And if they don't have them, they may shy away from you and choose someone else, which is problematic for you, obviously. And the other problem, which our friends at Babies Come True have indicated, is that sometimes some of the surrogacy agencies will charge again if there are multiple failures. So in that population, we are doing PGT, and we're going to continue it for a while, analyze it, see how many of the embryos we are creating come out abnormal. And if we find that it's really low, I think we're going to advocate for not doing it. If we find out it's moderate, then obviously we're going to continue doing it. But I think it's worth, kind of having almost like a conference with all the different facilities and agencies and saying, look, this is what we're finding. We're wasting time. We're wasting money. This is potentially harmful. Why are we doing this?
Low AMH, TTC 2.5 years, 3 failed IUIs, just had ectopic and lost a tube.
Oh,
but was
sorry.
a natural pregnancy.
Okay.
Waiting for funded IVF. Anything you'd recommend trying in the meantime? And found endometriosis during laparoscopy. 30 years old. Thank you for everything.
Well, if you're 30, you can do up to 3 more IUI. So that's a very reasonable approach to things. So I would actually consider doing more IUI. In the meantime, I would focus on anything you can do to improve your outcome, whether it's healthy choices for you or for your partner. If weight's an issue, work on the weight, exercise, reduce stress levels, fill yourself with as many healthy things as you can in terms of vitamins and supplements and so on. If you have endo, you should be on the endo supplements. So those are curcumin, NAC, resveratrol, and coenzyme Q10. And then actually the biggest thing is to not take a lot of time, because if you had endo surgery recently, you've got 6 months to a year before it'll come back. So that's a problem for sure. And the more times you do IUIs and you stim for it, the more you're getting more endo coming back. So maybe if you're, I don't know if you're our patient or not, but if you are, reach out and talk to us, because if you can't afford it, we will happily figure out something for you until you can, or see if there's some way of getting you a funded cycle either with us or with another facility as fast as possible, so you're not needing to do another surgery in order to maximize your chances. Good question.
Hi again. I love learning from the chat questions and how some questions make me think of my own.
Oh, cool.
What is considered regular period for a 43-year-old?
Every 21 to 35 days for any year-old is considered regular. I do find that 21 is very short and 35 is getting a little long. So, but those are the textbook definitions. So it's either every 21 all the way out to every 35 days apart, and anything in between is considered normal. If you're asking about frequency. If you're asking about duration or volume, that varies considerably.
What is the success rate of 41-year-old regular period, BMI 28, 2 normal PGTA tested embryos, 25%, 30% in first frozen embryo transfer?
25%, 30%?
She's asking.
Oh, in the first embryo transfer? Depends on who you're working with and what protocol they're using. It should be a minimum of 50%. With us, if we could optimize you, get your BMI and everything as perfect as possible, use the right protocol just for you, we're finding closer to about 70%. So that's what we would be targeting for you.
When is priming required in a cycle? Specialist wants to use Cineral and Zumion at start of flare cycle.
Oh, I know who that is. She's watching from Australia. Hey, yeah, priming. So Cineral and Zumidi. I don't know what the Zoom thing is, but Cineral is a GnRH agonist. You don't want to use that as priming. You want to use that as part of your flare. Priming is either human growth hormone, testosterone, DHEA, or estrogen. You should not do estrogen priming because, as we showed was it last week or the week before? I think it was last week. Estrogen priming is bad. It actually reduces your chances. And testosterone, DHEA, and human growth hormone are all really good. So DHEA is 3 months. Testosterone is a week before. And HGH, no one knows for sure, but we recommend 1 to 2 weeks before. But the rest of those, again, I don't know what Zumedion is, but Cineral you use in the stim part of the cycle. Now I got to look up what Zumedion is because it's going to drive me crazy. Yeah, fire away.
I recently had a chemical pregnancy, 4DPT. 4
days post-transfer, yeah.
I tested positive for COVID. Oh. I am fully vaxxed.
Okay.
Have you heard of COVID causing a chemical?
No. COVID will not cause you any problems in a pregnancy if you've been vaccinated, generally speaking. So it shouldn't cause any problems for you. Yeah, you'll be okay. Especially if you don't have a raging fever or problems like that, you should be all right.
Hi, Dr. VNT. I missed the first 25 minutes and really wanted to hear about the PGT. When will tonight's video be available on YouTube?
That's a Tarek question.
Well, what do you know?
What do you know?
That shows up.
Yeah, that's you, man. When will it be up?
We're going to have it up for tomorrow evening.
Tomorrow evening where? Tell everybody
on YouTube
where.
And Instagram.
On YouTube and Instagram?
Yeah.
Okay.
No, it'll only be on YouTube, actually. Sorry. This show will be, the live broadcast will always be live, but the edited and cleaned up version will be on the next day.
Tomorrow. On YouTube. There you have it. Tomorrow it is.
Well, there wasn't even was there a high tea or anything there? How often does that happen?
Zumedion. Is that, did you see how it's spelled?
Yeah, sure.
Zumedion.
Zumenon.
Zumenon. Oh, Zumenon?
Zumenon.
Oh.
Probably pronounced zoom in on.
Oh, so that has estrogen in it. Yeah, don't do that.
Don't do it.
So Zumenon has estrogen. Do not estrogen prime. Estrogen priming has been proven to be detrimental. So don't use Zoominon. Cineral is great for a flare, but don't use Zoominon. It's got estrogen. That's a bad idea.
Scroll. After having a full-term pregnancy following IVF, I had retained placenta at delivery.
Oh.
Do you think I should have any tests to check damage to my uterine line before an FET?
You should do fertility for infection, because almost always after those cases, we find this very disrupted bacteria in there. And you should have a saline infusion sonohysterogram or a hysteroscopy. Both of those would be critical.
Can the diagnostic testing, ultrasound, and blood tests at 12 weeks tell you gender?
No. You can get it from NIPT, the non-invasive prenatal test, but not any other way. Now, having said that, one of my ultrasound techs, whom I love dearly, believes that there is a way to tell, and she swears that it's very accurate. So I'm actually going to study it with her soon and see if it's a true thing or not. We'll figure it out. She has some angle of something she can measure.
I've heard of the angle measure.
Yeah, and she says that she can tell.
Really?
Paulina, yeah.
Paulina.
So we'll see.
Oh, interesting.
Yeah. P, I hope you're watching. Yeah.
Can the diagnostic testing, good evening, TV crew.
TV crew. We got to get that.
I like it. Should be on our shirts.
Yeah.
What is the reason you would prescribe 2.5 milligrams of letrozole instead of 5? My RE reduced my dose for this cycle, saying that my FSH is probably already high with 3 space 6. So I'm not sure if it's 36 or she forgot the decimal. Millimeter follicles on CD4.
No, she's saying 3 6-millimeter follicles.
Even better.
There you go.
There you go.
Yeah, I don't know. I mean, that doesn't make any sense. So there's no difference between 2.5 and 5 in terms of the number of follicles that you'll produce. It's the same number of follicles. It's just whether or not you'll actually respond. So with 2.5, you have a lower chance of responding, but with 5, you have a higher chance of responding, but not a higher chance of making multiple follicles. So I don't know what your RE is thinking, but we always use 5. I don't even bother with 2.5. It's too low. Same thing with Clomid. I use 100 milligrams of Clomid. I don't start at 50.
I don't start at 50 either.
Tarek doesn't start at 50.
Wasting time. Do you suggest going straight into an FET after an egg retrieval, or is it better to wait a few months?
So there's a Chinese study which showed that it's actually better to do it right away. And there's another study recently that showed that the longer you wait, the lower your chances are. So overall, it's probably better to be relatively soon. I don't think there's a value to rushing into it, but I think it makes sense to do it within a few months, which is what we do. So usually we'll do it within 2 to 3 months.
Yeah. After having a full-term pregnancy following IVF, I had double take there. I took estrogen until 10 weeks pregnancy. Is that okay?
Yeah, we use ours all the way up to 12, so that's fine. And then we wean our patients off. That has no net detrimental effects on the pregnancy.
I think they're laughing at me today. Can these lives be recorded here to watch again later?
Yes, they're all going to go up on YouTube. All our lives go on YouTube, so check out our YouTube channel. You know what? One of our patients and viewers actually offered to go through all of our YouTube videos and label them for us so that we could retitle them, because the early ones...
Oh, yeah, the early ones are...
Right.
Mm-hmm.
But I politely declined. Thank you. That was so sweet of you to offer, because he and I should be doing that together. So we'll do that. We got to sit down one day and just blast through it and get them done.
All the live videos
go
on YouTube as live streamed by date or something. So
right.
All there by date.
Right.
And then those episodes become syndicated shows on their own with the question of the fact or fiction elements.
Right. But we don't have the topic. So people don't know what the paper was.
Oh, on the live stream one.
On the live stream one.
Right.
So we got to put that on there. We got to say FFOF, letrozole, FFOF, whatever, right? So we got to retitle them.
Hi, Dr. VNT, smiley face.
Excellent.
I enjoy the smiley face. How long before transfer should you get the COVID booster?
2 months.
There you go. Nice and easy.
Nice and easy. I like that one.
Thoughts on this protocol for FET?
Okay, fire.
39 years old. Endo on left ovary. Estrogen followed by PIO and progesterone suppositories. That's it.
Definitely no. Well, sorry. Get surgery for your endometrioma. Go on Lupron and Letrozole for 3 months to suppress all the endo. Use a Letrozole protocol instead of estrogen because that's just re-stimulating your endo. Probably consider steroids and intralipids. Make sure you're on all the supplements for endo, which I mentioned earlier in the show. So NAC, resveratrol, curcumin, and coenzyme Q10. Use progesterone in oil and vaginal suppositories. Get your levels checked. It's a whole to do when you're treating patients with endo. What you're getting is cookie cutter medicine, and I would never advocate for that personally. Sorry. Cookie cutter medicine doesn't work. You need individualized care. They're giving you the same care they would give anybody else. That is not an appropriate approach for a fertility patient that's investing all their time, all their emotion, all their psychological battles, all the warrior mornings, noons, and nights, all of the horrible, shots that you've had to do, the 2-foot long needle we shot up God knows where, the pain, the discomfort, all of the questions that you've had to answer from family members and friends about why it hasn't happened yet, to get the same care everybody else is getting, that is not okay. I just am mortally opposed to that.
I think they thank you for that.
Well, I hope so. Yeah. I
Also,
will never do cookie cutter medicine.
I have just a comment here. I'm not sure what it is. I have 3 6-millimeter follicles. Oh,
Yeah, that was the other one. Yeah.
Yeah, she's good.
Yep.
Should I prime with anything before retrieval if my AMH is 0.27 and AFC 4 to 6?
Should I what before retrieval?
Prime with anything before retrieval.
Oh.
42 years old.
Yeah.
Also, is a 28-millimeter follicle at trigger too big?
Yes to the 28. That's too big in my opinion. You should prime with, you could prime with HGH, human growth hormone, testosterone, and we would definitely put you on 3 months of DHEA.
Hi, Dr. VNT. I have had 2 unassisted pregnancies at 36, 38, and have 2 healthy boys.
Okay.
I have always had low AMH.
Okay.
I'm 40, 2 biochemicals this year, 1 a euploid day 7. Thoughts?
Well, day 7, even euploid has a low chance of success. It's only about 15-20%. So that's pretty low. I'm sorry you've gone through that. As far as thoughts, I mean, if you're already doing IVF, but you previously were successful on your own, I guess I'd be asking why you're doing IVF. It'd probably be ideal to avoid that for you because it's just costly. But if you're trying to hurry or want to do it before, your ovaries are too weak, make sure that the protocol they're using for you is optimized for you. Because with diminished ovarian reserve in your age, you're not the same as everybody else. So there are tricks we can use to try and improve it for you. Obviously, there's no guarantee, but we like to try everything we can. I don't believe in just doing the same thing over and over again.
What IVF protocol would you recommend for someone that's 35 with low AMH, 4.7 picomoles per liter, high FSH 20, and low AFC 5? What types of IVF is best? Standard, duo, natural cycle? Question mark.
It would depend on how you've responded in the past. If you've had a past stim, that would help guide me a lot. If you have not had a past stim, I'd probably start with a, kind of reasonable approach for you, which would be DHEA, human growth hormone. We like the microdose flare, so we would try to flare you. Maybe testosterone priming as well. reasonable dose of medications. I'm not going over 300 anymore because there was a lot of research they presented at the recent conference in Italy that said it really isn't of any value. So we'll probably use Recavel for you and Menopur, 150 Menopur, maybe like 12, 13, 14 units of Recavel. Don't let you go past 12 days max, and then do the Retrieval double trigger. And we would use Letrozole in that cycle as well because it's been shown to be beneficial for the stim. If that worked, great. If that didn't work or you had previously failed with something similar, I'd actually go straight to natural cycle IVF for you. Yeah. And I'm sorry you're going through that at a young age. That's difficult. Reach out if you need some mental health resources.
You are made for social media. Seriously, thank you to the ERA test for sucking.
That's awesome. Well, you know what? Someone on the Zoom today said they felt like they were talking to a celebrity. And I always find that comment funny because I'm like totally an ordinary guy. Tarek and I talk about TV shows and food and movies and cars, and we're just ordinary people. So I am by no means a celebrity. I'm just very passionate about what I do.
Hi, Dr. VNT. Lining during IVF cycles never been more than 5 millimeters.
Oh, okay.
First FET protocol includes BCP, start with Lupron, Estrogen, Neupogen, Interlipids, HGH, Viagra, aspirin, Thals. Also, should I do a mock transfer?
Well, I've never been a big believer in mock transfers because if it works, you should just transfer. Why would you have to start the whole thing all over again? So should you cancel a not good transfer? Yes. But should you do a mock in advance? No, because that doesn't make any sense. Thoughts? You're on a bunch of the stuff we would recommend. Before you do all of that, I would just see what you're like, not stimulated, like in your natural cycle, to see if just your natural cycle helps your lining thicken. I wouldn't use birth control. That could potentially thin your lining, so that I would avoid. And then the other things you did not mention were PRP, and did she say Neupogen?
Neupogen, yeah.
She did. So PRP would be the other one that we would go for, and yeah, I think you hit on all the other things that we would try. PRP does work well.
If it's been 1.5 years since my endo surgery, should I still have another before transfer?
Ooh, if you're symptomatic, yes. If they kept you suppressed in the meantime, no. If you were doing stimulation of any kind in between, yes. So it depends on your specific case, but the effect of the surgery is generally considered to only be effective for 6 months to a year. 18 months is kind of cutting it close. I'd probably try and buy the same effect by using Lupron and Letrozole for a few months so you're not exposed to another surgery, but it also depends on how bad your endo was and what you did in between and whether or not you have symptoms coming back.
Bunch
Good
of
question.
people are commenting saying they also think you're a celebrity. Just putting it out there.
I am totally not. I'm genuinely not. I'm like an ordinary guy. I go home, I goof around with my family. I love my kids. I'm not a celebrity. I'm an ordinary guy, very passionate about my work, very passionate about helping you. But like, I'm not on the news 24/7 or anything. So yeah.
So, people are noticing.
That's pretty funny. Well, thank you, everybody. That's hilarious. But no, it's not my personality for sure.
Is DHA good for the quality of eggs? Should it take before IVF?
Yeah. So we've reviewed that on the show. We have videos on it. And there's no question that the meta-analyses on DHEA definitely favor using it. So in the past, it was really kind of up and down. People weren't sure. There's a lot of data out there now that supports it. It's kind of hard to argue with that. So we've been using it quite a lot now. I used it initially, then I kind of stopped because the studies were like, we're not sure. And then now we've gone back to using it.
I'm really surprised now with how fast you answer the question. I'm trying to flip through Instagram and YouTube. Dr. V.
Dr. V.
This is just for you.
Just for me. Okay. Yeah. You know, for the first time ever, they actually directly asked you a question.
I
It
was
was,
honored.
it was like a Tarek question. Yeah.
Yeah, it's true.
Yeah.
Anytime, guys.
Yeah. I can step out. You guys can have a chat with Tarek.
Dr. V, I tested positive for mono this spring,
Oh,
and I'm still testing positive 3 months later.
yeah.
How long should I wait for an FET? And can recent Epstein-Barr infection cause birth defects?
Recent can if the virus is still alive in you, but not 3 months later. Although I mean, listen, it's been forever since I looked at Epstein-Barr virus physiology and virology, but that's something we would ask an infectious disease specialist, or we'd have to look up. I would think by 3 months you should be clear of active virus. So you should be okay now, but I would check with a virologist or an infectious disease specialist to make sure. Otherwise, have your doc look it up on UpToDate or pull up an article. And if it's with us, then let me know and I'll pull up an article.
Do you need a prescription for DHEA in Canada?
Yes, you do.
Easy.
Yeah.
Would you ever double trigger an IUI?
Double trigger an IUI? Would I? Sure. Do you need to? Probably not. I mean, IUI is fairly low key and the Lupron's more expensive than the cost of our IUI. So, I mean, I'd probably be a little bit reluctant to make you spend that much money for IUI, but remember that part of the reason we use a GnRH agonist for trigger is because of the fact that we're trying to avoid hyperstimulation. And then you need to add in that little bit of HCG because it actually gives you better outcomes. But when you're doing IUI, you're not going to worry about hyperstim because you're not triggering the patients if they have 10 eggs. If they have 2 or 3, they're almost never going to hyperstimulate with 2 or 3 eggs. So you can just use a full dose of HCG and you'll get the benefits of everything. Different reasons for the trigger there. It's
902.
902. What are we doing? 905?
Sure.
Okay. Is it a busy show?
Well, it's good.
It was good?
Yeah,
Lots of people there?
Yeah.
Okay.
What is a natural cycle IVF?
Oh, natural cycle IVF is where you basically don't take meds. So we just let you go through your natural cycle. We wait till you've got about a 13 millimeter follicle. You take 1 vial of Menopur, 75 units, 1 Cetrotide or Orgalutran, it doesn't matter. We watch you for about 3 days, wait till it's about a 17, 18 millimeter follicle, 10,000 units of HCG, go in and fetch the egg, turn it into an embryo. The quality is usually amazing. So we love doing that. It's a little expensive for the value because you're only getting 1 embryo, but it does work damn well. And we've had great successes. I have one patient that has 2 babies with us straight from that. And I love that family dearly. Very nice people.
40.
Okay.
DOR.
Yeah.
AMH 0.26.
Ooh.
AFC 6.
Okay.
I'm doing a microdose Lupron filler protocol with estrogen priming.
Don't do estrogen priming.
My REI refuses to not prime with estrogen. You can't make this stuff up, you know? Anyways, I can optimize estrogen priming. I'm taking DHEA.
Well, your REI is not going to know what you're taking. So just don't take the estrogen. They're actually decreasing your live birth rate. That's what that study showed. It was a randomized controlled trial. You cannot argue with an RCT. Don't estrogen prime. It's going to decrease your chances of success. Skip it. Take testosterone instead. That's crazy. My REI refuses. You know, I've almost never refused someone anything. Like, it's very rare. Okay, granted, if it's illegal, I'm not going to do it. But barring something illegal, like I had a patient we were on the phone with for almost an hour on Sunday who had lots of concerns about our protocol because she had read her own literature and wanted something very different, which I totally respect. And I told her, like, I love the fact that you're educated about this. I love the fact that you want to do your thing. It's not what I would think is good for you, but that's okay. Like, I don't have to do what I think is good for you, because if you want to try it your way, we'll try it your way. If it works, hallelujah. If it doesn't work, my way's not going anywhere. We can always try it my way. And as long as you're comfortable with that, based on how many embryos you have, Bob's your uncle. I'm good with that. Let's try it. And that's the way it should be. Like, my job isn't to impose on you. My job is to help you. And sometimes helping you is navigating with you. Sometimes it's navigating for you. And most of the time it's just like holding your hand on the journey you're on so that you feel secure every time you take your next step. Holding your hand is not me dragging you behind me. It's, or shoving you ahead of me. It's me holding your hand. I'm there to support you. And that's the role of a true healer and a true physician. It's to support patients. It's not to impose. That's what jerks do, not what doctors should be doing. I think we end it right there. Yeah, Tarek and I had the same idea. Okay, well, listen, I'm sorry your IUI is not being friendly and supportive. Come see us. I'll be friendly and supportive. And I hope all of you have a successful journey. I hope any one of you that's doing retrievals and transfers this week is all aces and everything works out great. I hope you enjoyed the show tonight. Make sure you click like and follow or subscribe, depending on which of the multitudinous different platforms we're using. And we will see you again next week on Fertility Fact or Fiction. Have a great night, guys.